This was a super cool interview by Dr. Mary Pardee. She's based out of Los Angeles. She's a naturopathic doctor. A lot of you guys ask me, how come you're always posting videos? It's against chiropractors and against functional medicine and against all this stuff. So I'm not. I'm an equal opportunity debunker. I post videos basically debunking people that are on the wrong side of the evidence or the wrong side of science. Dr. Mary is on the correct side of science. We had this amazing interview. It was about women's heart disease and debunking all the myths surrounding cholesterol. She's super evidence-based. She's with the science. She's always up to date, always asking the right questions, making the right conclusions, using the right data and evidence, supporting the right types of people. This was a super fun podcast. I think you guys will enjoy it. I wasn't ready for what happened at the end. She had a list of rapid fire questions. I will point out though that some of you guys asked me, why don't you support, alternative medicine? Multiple people who are not physicians have endorsed my cholesterol book, and I've put it up here as well as the back cover. There's Dr. Matthew Nagra, who's a naturopathic doctor. There's Dr. Ron Grisanti, who's a doctor of chiropractic. These are evidence-based practitioners who have supported my book and endorsed it. So it really has nothing to do with what your degree is. There are plenty of cardiologists, as the video before this you have seen. There are plenty of cardiologists that make no sense and are using the wrong evidence and talking, nonsense about heart disease and cardiology. So it has nothing to do with that, really. It has to do with, are you following the evidence? Are you accurate? Do you follow the scientific method? How accurate are you? So with that all said, take a listen to this wonderful podcast. I think you guys will enjoy it. It was definitely a lot of fun, and hopefully we'll be bringing you more amazing heart health information so that you learn how to live longer, happier, and healthier without the BS and nonsense.
Welcome to the Modern Wellness Podcast. I'm your host, Dr. Mary Pardee. This podcast, along with my private practice in LA and my newsletter, all are aimed to providing you evidence-based information around preventative medicine, longevity, and health in general. Join me in dispelling health myths as well as cutting through the noise that is social media. I hope that whether you want to optimize your performance or just in general get healthier, the Modern Wellness Podcast will help you do that. I'm here today with Dr. Alo. Dr. Alo is obsessed with eradicating heart disease and longevity. He's a board-certified cardiologist and certified personal trainer. He also practices obesity medicine and advanced lipids, which we're going to be talking about today. He's based out of Northwest Ohio. Dr. Alo grew up in Toledo, Ohio, attending St. John's Jesuit High School, then went on to complete an economics degree and graduated magna cum laude from the University of Toledo. He currently teaches on all the social media platforms. Please go follow him. His handle's at dr.alo. And you can download the free Dr. Alo app on your phone to take free courses in the Alo Academy and his online community. I'm so excited today to talk to him all about heart disease, how to prevent heart disease, lipids, and so much more. I really hope you enjoyed this episode. Thanks for joining me on a Saturday. I really appreciate it.
Yeah, thanks for having me.
Of course. I'm really excited for today's interview, and I know you've done a million of these, so this is par for the course for you. The reason I wanted to have you on mine is I feel like I have a group of people who are more prone to kind of question the cholesterol piece, question the standard treatments, and you have so much valuable information. I am an owner of your book, which I'm obsessed with, The Cholesterol Truths. It's more of a textbook. I went to bring it to my friend's house and I'm like, this thing is really heavy.
Yeah, it is. It weighs almost 5 pounds. It took a long time to write myself. I started it. It was like a 2-year project almost. I didn't realize it was going to take that long. I thought I'd put together a quick short book on, dispelling most of the myths around cholesterol. And more myths kept coming up. People kept asking questions. I kept adding more. Then I brought on Dr. Thomas Dayspring, which I'm sure you've heard of him. He's the world's greatest lipid editor, or lipid speaker, teacher. He's written multiple chapters and multiple textbooks on cholesterol and lipids. And it was almost like starting from scratch again. We went back through the book. The book at one point was 780 some odd pages because we included so many of the graphics from all the different studies, and then trying to get those licensed and allowed to use them became a nightmare. They were going to charge almost $4,000 per image. So that did not sound like it was going to cost $4 million. So we got rid of all that. And we decided just have an illustrator do some of the images, or at least something similar. And then we included everything in a supplemental guide that you can, if you know, that front page there, if you just go to that front page and click that link, you can get the supplemental guide. You can get the lipid masterclass for free, which includes all of Dr. Dayspring's lectures and animated lectures and notes, plus tons of lectures that I've given on cholesterol and lipids. And anytime he gives another lecture or video or animated video or presentation, we add it in there. So it was a long project, but I feel like it was worth it, because it seems like you said, a lot of people online and all over, you know, not just online, don't seem to understand, or they're heavily influenced by these people that are trying to make it sound like cholesterol is okay, or it's not a big deal, or, you know, if you're quote unquote metabolically healthy, then cholesterol is not a problem, and all this kind of stuff. So I wanted to put it out there so that people kind of know, you know, that this is like a good, reliable source of information that is not trying to, you know, sell you some nonsense or fool you into, you know, whatever it might be.
Yeah, no, and I really appreciate it. And you educate so much on all the social media platforms. I actually don't know if you remember, but I messaged you one time randomly a few months ago, and I was like, hey, what do you think about this in a patient kind of thing? And you answered, and I was like, wow, like so selfless and just like clearly really trying to help people, which I really appreciate. And one of the other things I want to mention is, you know, I'm really passionate about debunking things in health, because I'm in the integrative space in terms of like promoting lifestyle and nutrition and exercise. And there's so much BS in the integrated space as well. And I come from a unique place where I remember being in my 20s and questioning cholesterol. And like I had people that I looked up to in the space, and they were saying all of these one-liners, you know, like people that have heart attacks, a lot of them have normal cholesterol levels, all the one-liners that you've already heard. And when they're
made a chapter about every single one of those.
Okay, great. So I go through the one-liners
about that.
But I remember being on the other side of this, listening and being like, wow, that makes sense. Yeah, maybe it doesn't. Maybe we shouldn't. Like, maybe we shouldn't care. Maybe this is BS. And so I really do empathize and understand where people are coming from, because I've kind of been there. And then once you actually really, and the other thought that came to mind, because I'm interested in the psychology behind this, because I'm like, why are people so like stuck in this? And I feel like part of it is that people come across so polarizing, because you have to do that to sell something on social media, right? Like you have to win people's attention. But that's all to say, I'm just really glad that you're here today, and I want to go through some of the things.
Yeah, well, I'm happy to be here. I think part of, and I've thought about that a lot, like why are people prone into believing what they hear online? I've had long discussions about this. I think some of it is because if you can blame some big boogeyman or some big conspiracy theory, like big pharma, big food. I mean, nutritionists tell me this stuff all the time. Registered dietitians, you know, they have the same issue where people are just saying a bunch of crazy stuff online. But if you can blame some power that you can't control, or something that is out of your control, that you're not responsible anymore. Like if you can say, well, it's the food industry, or it's big tobacco, or it's, you know, the medical, you know, establishment, all these Western medicine doctors don't want to help us. They want us to stay sick or whatever. If you can blame some huge power that you can't control, then for whatever reason, it takes a little bit of the onus or the blame off of you, or you can say, well, you know, we're doing what we can, but we got all these forces in the universe against us. Right.
I think there's there's some of that. I think when I think about like, what was I thinking when I look back, there's like embarrassment for me. I'm like, well, how did I like think any of these things? But I think part of it was I had a belief at one point. I can remember thinking, wow, these cardiologists just don't know X, Y, and Z. Like they haven't figured out X, Y, and Z. And then you clearly like meet people like you, and you're like, oh shit, they fucking know all of it. And you come out, if you really dig through all of the research, you come out to, okay, this is clearly where we are right now in the scientific method. Like this is the leading thing.
No, I agree. And I think, I mean, some of it, the cardiologists, I mean, you know, you'll be surprised how many cardiologists do not also know the in-depth stuff about cholesterol. And I don't blame them. That's not, you know, it's part of what we do, but it's not everything that we do. So there's a lot of people, even physicians, that fall for this stuff. They hear a guy like Paul Saladino out there telling people that plants are trying to kill you and you should never eat plants, or whatever his theory is now. I know he changed it, but they fall for it. It's like, oh, here's a doctor. He seems well educated. He has a lot of followers. He has, he cites a couple studies here and there. At least he flashes them on the screen. He doesn't read them, it appears, but he flashes some studies on the screen. He's got 1 million followers. Maybe he's reliable. And it's easy to fall for that when you have social proof that, this person has 1 million followers versus, this guy only has 2. So I think part of it is even physicians fall for some of these things because it's not their, expertise or what have you. Even like, other cardiologists I know, like, well, what about this one study about saturated fat? And, they came up with this thing and they don't realize it wasn't a study. It was an opinion piece. And, the actual studies don't show that. So It's very confusing, the scientific method, and not being able to understand studies and research is not that easy. Even for highly educated people, it's still not that easy. And it takes a lot to be able to know what you're looking at and what you're reading and what you're not reading. So hopefully people like you and I can keep debunking these things so that people can, do the right thing, I guess, make good choices.
Yeah. Okay. Well, let's get into it then. First, let's just talk about ASCVD. So we're talking about atherosclerosis. Why do we care about it? So what are the risks, big picture? I don't know if you got your model. I'm obsessed with the model that you have. I'm like, where do I buy that thing?
Yeah, we'll get to these. So maybe before that, this is a heart. There's arteries that feed the various muscles in the heart. The problem is when you have lipoprotein in excess of a specific concentration gradient, they start to dump their cholesterol, the yellow stuff on the inside, into your arterial walls. And this is not, there's a lot of things in science that we're still trying to understand. There's we don't understand the brain maybe fully, or, certain things maybe fully, but there are some things that we know really well. And one of them is atherosclerosis. The cause of atherosclerosis is an excess amount of lipoproteins in your bloodstream, especially of the LDL variety and the cholesterol that is in them. And this is not considered debatable in the medical community. Now, it might, there might be some debates as to what if this activates that or whatever, like little things, but there's nobody really debating the causal role of LDL cholesterol and atherosclerosis. So the reason we care about atherosclerosis is because the arteries that go to your heart, they also travel into your brain. They travel to your kidneys. They travel to every organ system, your liver, your legs, your muscles, your eyes even. They travel to every organ system, and if you have a high concentration of cholesterol, you are plugging up all of these arteries. And the most recent studies have shown, and I know that was one of the questions you had, was that carotid artery disease, or lipoproteins getting into your brain have been shown to increase the risk of dementia, Alzheimer's, ALS, all neurodegenerative diseases, Parkinson's, multiple sclerosis, all of that. And anybody who was put on statins actually had a reduced event rate and incidence and prevalence of these neurodegenerative diseases. So, and the other big thing about atherosclerosis that's super important is it's something that's nearly completely preventable.
Yeah.
We have people that are born with genetics where their LDL cholesterol, this is called hypo-beta lipoproteinemia. These are people born with cholesterol levels, LDL levels in the 5 to maybe 15 range. And I have several friends with these genetics, and they will never have heart disease. They will never get atherosclerosis. They will never get any of this stuff that has to do with cholesterol being elevated. They will get other things, obviously, but these type of genetics are, when you go to the blue zones and look at this, and there's an entire chapter on the blue zones and the genetics of the blue zones. But these are people that if they do everything else kind of right, and even if they don't, they have a little bit more buffer zone. But if they do most other things right in their life, they should live a very long life, definitely over 90 and perhaps, into the hundreds range. If they lift weights and exercise and, do all the things to stay strong, they should still be able to go on walks and play with the great grandchildren and, all that stuff. But the reason we're obsessed with heart disease, it's the most studied field in medicine. Cholesterol is the most studied molecule in medicine because it's the number one killer. Now, it has gone down. People say, well, if you guys are doing such a great job and statins are so amazing and all these medications are so amazing, why is heart disease still the number one killer? Well, we've had a 90% reduction in deaths from heart disease since 1968. And if you go back all the way to the 1930s, when we kind of figured out what heart disease was, it's even more than that. Now, cancer and heart disease are both killers, but they're about to crisscross because people are surviving longer with cancer and people are surviving longer with heart disease, then the killing of it, I don't know if that's the right word or not, but the death rates from those who are about to crisscross, where the death from heart disease is going to be much lower than the death for cancer over the next 2 to 5 years or so. You're going to have cancer as the number one killer and heart disease not so much. Men and women, absolutely. Yeah. The number one killer of women is still heart disease. People think it's breast cancer or ovarian cancer, any of the female cancers. It's not. It's still heart disease, which is why we harp on it so much. We wear red in February. I know it's March now, but we wear red in February to bring about awareness, mainly because women and like other minorities, African Americans, Hispanics, people with lower socioeconomic backgrounds are usually undertreated or ignored, or they weren't in studies as much. Now almost every study requires to have a balanced ratio of men to women, amount of minorities that represents the general population. Like if it's 12% of this, then you have 12% of that in the study. You're now supposed to do all that, and we are finding that women benefit from these treatments or these, modalities. And even if it's just like diet interventions, every study, every randomized control trial that has ever been done where we lowered cholesterol, and this is like, we lowered it, whether it was diet or exercise, or eating more fiber, whatever it is, not just medications, but every intervention where we've lowered cholesterol, only good things happen. People lived longer. They had less heart attacks, less strokes, all-cause mortality went down. Almost anything you can imagine improved. There are no studies where we lowered cholesterol by any means possible. Like I said, even diet and exercise, and something bad happened. So that is, and those are randomized control trials. People say, well, what about this Swedish cohort where, the people with higher cholesterol lived longer? First of all, that turned out to not be true. The authors published a retraction and said, no, that was not true. There was no such, signal in that cohort. But there will be people that will say that, and that's not an actual study. That's just following people around, for their lives and seeing what happens with them. It turned out that wasn't true. Many of these studies turn out to not be true. People with the lowest cholesterols die more because they have cancer. And that is a true signal. People with very low cholesterols have cancer of some sort, and they die from that. They're malnourished, they're cachectic. I've diagnosed many people with cancer because their HDL and LDL were like 10, 5, 20, 30, like insanely low numbers. They're not on a medicine. They're not on any reason why it should be low. And you're like, something's not right here. Send them to hematology oncology, and they'll go, and it turns out they have some kind of cancer. So
yeah, and let's just double click on that, because it's not the low cholesterol causing an issue. It's a symptom of an underlying issue.
Right. It's called reverse causality in medicine. The low cholesterol didn't cause them to die. The cancer caused them to die. They just happen to have low cholesterol. It also goes for BMI. Like they end up with the lowest BMIs because they're so malnourished. Does that mean if you're overweight, you're going to live longer? No, it just means that people have really end-stage COPD, cancer, many of these other, diseases end up with the smallest waistlines, the lowest BMIs, the lowest blood sugars, A1Cs, the lowest everything, including LDL cholesterol, and they die subsequently, in addition to all that, because of whatever end-stage disease they have. It's not the low cholesterol that got them, it's the disease that they had. So I think it's important to understand reverse causality. And then in the opposite studies where they watch a cohort and see who lives to 100, there's survivorship bias. There's a huge amount of survivorship bias. They didn't even start checking cholesterols in many of these studies till people were already over the age of 65, which means the people that died younger from heart disease were not even included in the cohort, which back then we had no treatments for cholesterol and people died. It was like the 1920s and 30s when these people were born. So there's a lot of bias. And if you don't understand studies and statistics well enough, you might pick one of these things up and run with it. And now all your followers think that, if you want to live to 100, you need to have higher cholesterol, which even the authors retracted and said, no, that was false. We misprinted that one.
Yeah. And okay, so just to kind of head scratcher in terms of why do you think there are some people that will have high cholesterol and never have an incident? Do you think it's just rolling the dice kind of thing? And just like there's going to be people that smoke and never get cancer, right?
Yeah, that's exactly what it is. There are some people, and it's not a lot. Like we're not talking like hundreds of thousands of people. Like the vast majority of people, if you smoke, you're going to get cancer. The vast majority of people, if you are overweight, you're going to end up with some kind of issue. The vast majority of people, if you have high cholesterol, you're going to have atherosclerosis. Now, there may be some protective other genetics. You could have like, and, there's a whole chapter on the genetics of longevity in my book. But if you have some of the other genes that are a little bit more protective, despite the high cholesterol, maybe there's some reason why your endothelium doesn't retain the particles or something happens there. And, that's why they end up not getting it. But it's not a huge portion, it's like a fraction of a percent. So people who want to risk it or chance it, it's not a smart idea. You shouldn't be like, well, I might be one of those people. My dad lived to 100. Well, maybe not. We don't know.
Right. Yeah. How I describe it to people is literally rolling the dice. I'm like, well, do you want to gamble? Do you want to put all your money on red? Okay. So for ASCVD, we've obviously talked about LDL, ApoB being a huge contributor. Any other things that increase your risk for
ApoB? Just to back up a little bit, I don't know that we mentioned that, but ApoB, and I'll describe this because I know your people are mostly audio. This is a lipoprotein particle. This is imagine a baseball. On the inside of the baseball, let's say this is a low density lipoprotein. On the inside of it is the cholesterol. This yellow, fat-like, waxy substance is cholesterol. This blue structural protein that surrounds it, imagine like the strings on a baseball. It's like a blue structural protein that engulfs it or surrounds it, where all these phospholipids or the cell membrane is on. That is the ApoB particle. The reason that ApoB is a bit more accurate is because it's the total amount of particles that is the problem. Whether they contain a lot of cholesterol, a little bit of cholesterol, isn't as important. It's the total number of particles. Now, obviously, if there's more LDL cholesterol, there's probably more particles. And generally speaking, if there's less LDL cholesterol, there's usually less particles. The ApoB measures exactly the particle counts. It measures VLDL, chylomicrons, IDLs, and LDLs. They all have ApoB particles of some sort on them. The chylomicrons are B48s. The rest of them are B100s. They all get measured. So you're measuring all the potentially atherogenic particles in your bloodstream in a concentration gradient when you measure ApoB. The nice thing about ApoB is you don't need to be fasting. You can just show up, have it checked, and it is a target of treatment. We know that if your ApoB is below 60, and even LDL cholesterol, if it's below 60, based on the PISA trial, the Jupiter trial, multiple other trials, you're probably not laying down plaque. In fact, you may be even regressing your plaque. But 60 seems to kind of be the cutoff. If you're above 60 milligrams per deciliter, if you're above 60, most people are probably laying down plaque. If you're below 60, the lower and lower, the more likely that is impossible. So the Jupiter trial, I think around 57 was the cutoff. PISA was around 60. There was another one that was right around 55. So it's somewhere in that range, 55, 60. If you're below that, there's almost no way on earth you are laying down plaque. If you're higher than that, the lifetime exposure to high LDL cholesterol determines, along with your genetics, how much plaque you lay down and how quickly. That can be accelerated. People say, well, what about smoking and diabetes and all this? There are a number of factors that can accelerate it. Diabetes is one of them, smoking, hypertension, obesity, socioeconomic factors, lack of fruit and fiber, lack of vegetables, lack of exercise. All of these things can accelerate or decelerate, like fiber and fruit obviously would decelerate. Exercise would decelerate. Quitting smoking, but all of these things would accelerate or decelerate it. But the underlying necessary thing that must be there would have to be LDL cholesterol. If you have high LDL cholesterol, then all of these things can speed it up or slow it down. If you don't have it, like these people with hypobeta lipoproteinemia, or we suppress it with medications or lifestyle or whatever, then that's highly unlikely. In fact, sometimes nearly impossible at certain levels to ever occur.
So say you medicate somebody, you're getting their ApoB to 50 and they're a smoker, they've got diabetes, you're still not worried about I know you're worried about other things, right? But are you worried about ASCVD plaque formation in the arteries?
If they were below 40, I would say probably not. Now, there may be cases where that happens. Obviously, there's always random things that happen. But, these people with these LDLs of like 15, 10, 20, 25, they almost never have atherosclerosis no matter what they do. If you're like in the 50 range, 50 to 60, you still could have it, probably just at a much slower pace. It can accelerate the more of these things you add on to it. But generally speaking, very unlikely unless you increase it somehow.
Right. Obviously, we're not advocating for taking up the bad behaviors for many other reasons. But if money was no issue, we're not talking about insurance, like take that off the table. Would you just run an ApoE or ApoB versus a lipid panel? Or do you run both of them and why?
So you still need three. If I had to pick just one, yeah, it would probably be an ApoB, but you still need a lipoprotein A.
Oh, but let's wait on the LP little a in a second.
Okay.
But when you're just talking about, like, I'm looking at like any reason to know LDL-C if you have your ApoB, basically.
You do need a fasting lipid panel, just mainly for fasting triglycerides. Because that helps us figure out. I mean, the problem is with it, it's very genetically determined, but it could help you figure out if someone's diabetes is well controlled or if they're diabetic or not, whether they're pre-diabetic, how bad it is. If they're alcoholic, it can be higher. If they're overweight, it can be higher. If they have chronic kidney disease, it can be higher, just so we have a number. Because some people with fasting triglycerides of over 500, that's kind of a medical emergency. That's called hypertriglyceridemia, which is a genetic condition where that can cause pancreatitis, which is could be very severe and life-threatening, and can also cause pancreatic cancer down the road. Sometimes these people come in with triglycerides of 2,000 to 3,000. Those are medical emergencies. Those need to come down as fast as possible to below 500. So 500 is kind of a cutoff for hypertriglyceridemia. So we still kind of need a fasting lipid panel for that mainly. Right. And then ApoB would be pretty much, the only thing you'd need after that.
Right. So you're I have all the time, I'll run a lipid panel, I'll run ApoB, and the triglycerides are completely normal, like not an issue, but
that's not an
LDL
issue.
cholesterol is high, ApoB is high, and from there on out, I track with ApoB only. Obviously retesting yearly to make sure the triglycerides stay normal.
Yeah, absolutely. If that's the case and you've already had at least a fasting lipid panel at some point, you could just do ApoB. Yeah. You don't need, and if they've already had a lipoprotein A, which I guess we can get into later, you don't need to check that again. You can just track ApoB only. And if they walk in your office like, oh, doc, I forgot to get tested. I forgot, this and that. They don't need to be fasting. They can just go get the ApoB. Absolutely. It's just a quick test. Whether you're fasting or not makes no difference.
Yeah, which is really nice. Okay, so let's say somebody does have elevated LDL-C, ApoB. What are the things from diet, lifestyle that will actually put a dent in this?
So you'll be surprised, but there's really only like two. I know there's studies that show that this might lower it and that might lower it. True, but the two biggest levers, there's one huge lever, there's one that's kind of minimal, and the rest are okay. The single biggest thing you can do, and I'll go through all of them, there's like 10 or 12 of them, but the single biggest thing is reducing saturated fat intake. Without question, reducing saturated fat intake has the single biggest effect on LDL cholesterol. Now, a lot of how much of the effect it has depends on your underlying diet. If your diet is starting at like 3 sticks of butter a day and, fatty steak every day and eating the skin off the chicken and, downing all that stuff every day, it's going to make a humongous difference if you cut that out. If you eat a standard American diet and you kind of don't really eat a lot of butter, but sometimes, and you eat red meat once or twice a week, it's not going to have a huge impact, but it still will. So if you eat a mostly Mediterranean diet, then you're like very health conscious, no butter on anything, no saturated fat anyways, and maybe just a little sneaks here and there. Cause like even olive oil has some, and, chicken probably, has a little bit, eggs a little bit here and there. If you are eating mostly healthy food and you cut saturated fat intake, which is not a lot to cut because you're kind of already not eating it, you're going to have a small effect. 5 to 10% lowering of your LDL cholesterol. So a lot of it depends on what is your underlying diet. And a lot of times in diet and nutrition studies, when you're looking at adding a food or like evaluating a food like olive oil, like we're going to say, olive oil is good for you, but like compared to what are you substituting out or not substituting? You're just adding olive oil. You're just adding a lot of calories. If you're substituting a saturated fat for polyunsaturated or monounsaturated, then it makes a big difference. If you're taking out butter, for example, and eating walnuts or olive oil or anything, that would make a huge difference. But if you're not really consuming that stuff to begin with, just adding olive oil is just adding calories unless you're substituting something out. So the single biggest thing you can do is cut out saturated fat. That can have a wide amount of effect, anywhere from 3 to 5%. Lowering up to sometimes 60, 70, even 80% if you're one of these people that eats a lot of saturated fat. Right. There are some people that eat a keto style diet, and I know there's ways to do it that are a little bit healthier. But if you're eating a lot of, steak and butter, like there's this lady on YouTube called Steak and Butter Gal.
Yeah, I'm familiar.
Yeah, I reviewed her labs. They were horrific. You should watch that video. But if you are eating just steak and butter and those kind of things and you cut that out, it's going to make a big difference. Her LDL, I believe, was like around 70 to start. Once she adopted her new diet, I think it went up to like 280 or something like that.
Wow.
That's a huge difference. That's like a 50 to 60% drop, maybe more, just from changing your diet around. The other big mover of cholesterol in terms of lifestyle is going to be adding fiber. Now, it's not a huge effect. Studies have shown anywhere from a 1% to 2% reduction to maybe 7%. If everything is tightly controlled and some saturated fat was removed, maybe a 15% reduction, but that's almost impossible without taking out saturated fat. So if the diet intervention was only adding fiber, you would have a single-digit reduction in LDL cholesterol. We're talking like 1% to 2%, maybe 5 or 7 at the most, at the higher end. So not a big mover there, but definitely something else. Now, the rest of this stuff has almost minimal effect to no effect. People think exercise reduces cholesterol. It generally does not.
Really? That's something, you're surprising me with that one.
Yeah, it's actually
What if somebody's sedentary and starts exercising? Like, still not a big...
It's very good for you. It's good for your heart. It's good for your brain. It's good for everything. It's just not going to lower cholesterol. But yeah, that's a surprising thing. There are studies that have shown that exercise reduces cholesterol, but it's beyond the scope of the amount of exercise any human can do. Like, none of us can do running 20 miles a day or some insane amount of exercise. Like, that's not even like, you're not going to tell a 60-year-old patient with high cholesterol, you need to run 20 miles a day. They're just going to look at you and think you're nuts. They'd be like, just give me the injection, doc, or whatever it might be. But yeah, it's nearly impossible with exercise. I'm not saying it's not possible. Certainly it is, but it's like beyond the scope of most human capability.
You'll get effects from triglycerides with improving, like if you're insulin resistant or pre-diabetic from exercise. Yeah.
Yeah, absolutely. If you lift weights, and especially if you lift weights and cut calories, assuming you're overweight. If you're not overweight, though, it's going to be a different story. So there's a lot of nuance. So if you are overweight, any amount of weight loss, however you do it, is going to improve triglycerides, which is what this steak and butter gal did. She lost 20 pounds and her triglycerides went down, surprise. But she's eating just steak and butter, literally.
Okay. So what about if somebody has high triglycerides, they're pre-diabetic, let's say, and they start exercising, they don't lose weight, their body composition improves, still get an improvement, yeah or no?
Yeah, you'll definitely get an improvement because you've built muscle in and of itself. If you've built muscle, even if your weight does not change at all, they've lost fat and gained muscle. Any amount of fat loss will help with that. Because fat is ultimately triglycerides, all the excess triglycerides. When you first consume a meal or a fatty meal, the triglycerides are packaged up into these things called chylomicrons, which leave your intestines, go out the lymphatic system, and go deliver triglycerides to your muscles that need them, and then the excess ultimately ends up in your fat tissue, and then they go back to the liver and are recycled, and then VLDLs too, also after a large meal, will also go deliver triglycerides. So the question is, if you build muscle but lose fat, any kind of fat loss generally will lower triglycerides. Building muscle in of itself helps with insulin resistance. There's this big misnomer out there, speaking of misnomers, that people think like you can completely reverse insulin resistance. You can get off meds for sure, depending on how mild or how bad it is. But you can't change your genetics. The problem is it's a genetic disorder. You either got it from your mom or your dad. You can even get off meds. Like if you lose enough weight and you get healthy, you build some muscle, start working out, you can probably get off meds. Not everybody. There's some people that are rail thin and still have pretty bad type 2 diabetes. There's just genetic variance in how bad it is. Some people are thin and skinny and work out every day, barely eat 600 calories and still have like the worst, possible type 2 diabetes you can imagine. Some people are 500-600 pounds and don't have these genetics at all. And like their A1C is like 4.6, insanely low level. So it's very genetically determined too. But I think one thing is we should not tell patients, like we shouldn't blame the patient, like patients, like, patient blaming, like, hey, stop eating jelly donuts. You gave yourself diabetes. No, they had the genetics for it, but, they gained weight. Sure, you can tell them to lose weight and that would certainly help. They may not get off meds fully, but the majority of people could get down to just maybe metformin or maybe not even that. So it really depends. But in the other terms and the other things lifestyle wise, it's all the usual suspects. Exercise more, stop smoking, reduce salt intake, all that kind of stuff. But definitely the single biggest movers, reduction in saturated fat, and then a little bit on the fiber side.
Okay. Yeah, I see the shame piece in cholesterol all the time, where people's cholesterol, will be 150 and they're like, oh, I don't want to have to take a medication. I can't believe I've gotten, like, they blame themselves for it a lot of the times. And I'm like, this is hugely genetic. You could be doing everything perfect and still have high cholesterol.
Yeah, absolutely. It's mostly genetically determined. There are certain things you can do, no matter what your genetics are. If you eat a lot of saturated fat, it's going to go up. There's almost nobody who is resistant to saturated fat intake. Some people it goes up a lot, some people not so much. So there are some people that are doing everything right. And they're in my comments like literally every day, like, Doc, you're right. I exercise every day. I eat only plants. I'm a vegetarian or a vegan or whatever it might be. And I still have insanely high cholesterol, or like higher than the current limits. Even insanely high. Some people are born with, familial hypercholesterolemia and all kinds of crazy genetics. But let's say it's just a little bit high. Let's say their LDL is like 120 to 140, somewhere in that range, but they're only plant eaters. And they wonder, like, how is this possible? Why is my cholesterol high? Well, your cholesterol, the majority of the cholesterol that is circulating in your bloodstream does not come from the food you eat. It comes from every cell in your body making it. Every cell in the human body makes cholesterol. And it gets trafficked back to the liver when we take blood out to draw it to see what your cholesterol is. That's the blood we're drawing. The dietary cholesterol that you consume, it contributes somewhat, and some people more than others. Some people are hyperabsorbers. Some people are not such hyperabsorbers, but it can contribute. It's just not as much as your body making its own cholesterol. So even vegans or whole food plant-based diet, people who don't even look at meat or fat, even if they avoid all fats, not just saturated, but even olive oil, canola oil, whatever, vegetable oils, even if they avoid all that stuff, there are a lot of people that will still have high cholesterol because it's the cholesterol your body's making, and the elimination is not keeping up with the synthesis. Your body's ability to remove cholesterol is not enough, can't keep up with your body's ability to make it. So some people are hyperabsorbers, some people are hypersynthesizers, and if there's a balance there. And if you can't get rid of it fast enough, then it's going to accumulate in your bloodstream, and that's when it starts to accumulate in your arteries and sometimes under your eyelids and other areas.
Yeah. Okay. And so we talked about the lifestyle things, and obviously medications are going to be a huge part of lowering LDL ApoB levels. What are the main ones that we'll be using in practice? And we'll go into some of the myths around this, because this is where a lot of it is.
So the good news is there's not that many options, but also there's way more options than we had even just 5 or 6 years ago. So your mainstay is going to be the cheap generic ones. Most insurances approve these because they're cheap and generic, and almost anybody could just buy them for 2 cents for a 90-day supply. These are your statin medications. All of them are generic with the exception of pitavastatin, which nobody uses because it's barely stronger than pravastatin. So mainly in the cardiology world, and probably in your world too, we use rosuvastatin. It's the most potent. It has the least amount of interactions and side effects. It's synthetic. Some of the older ones are the non-synthetic ones that are like literally basically fungus. The lovastatin, pravastatin, simvastatin. The newer ones like pitavastatin, atorvastatin, and rosuvastatin, which is Crestor, Lipitor, and it's actually called Livalo, but no one uses that one. But usually Crestor and Lipitor are the two most potent ones. They're synthetic. They have the least amount of interactions. They're very tolerated. They cost almost nothing. Like literally they're probably $0 on everybody's plan, and they work really well. The most potent one is Crestor. It can cause anywhere from a 35% to sometimes 65% reduction in most people's cholesterol. So I usually start people on Crestor and Zetia. So Crestor and statins usually block synthesis of cholesterol. Your cells in your body won't make as much. The other one is called Zetia or ezetimibe. It is also generic and usually cheap depending on the insurance. But that one blocks your intestines, the MPC-like receptor, from reabsorbing cholesterol. So what's the point of like all the cholesterol in your body getting back to your liver, eliminates it through the bile duct into your intestines, and then you reabsorb most of it. So Zetia sits in your intestines and makes it so that you don't reabsorb as much of it. It can cause anywhere from a 10 to maybe 25% additional reduction. By itself, it can cause like a 10 to 20% reduction. When you add it to like a potent statin like Crestor, you could see like a 60, 70% drop in people's cholesterol sometimes. We now recommend people not use the highest dose of a statin because the tolerability issues and side effects start to happen more, like, Crestor 40 or atorvastatin 80. We'd rather use like the 5, 10, 20, maybe 40 on the atorvastatin side, plus Zetia 10. You get a very potent lipid lowering, And all of the benefit and protection is confirmed from the lipid lowering, not really like what medications you use. In almost every study that's ever been done, if LDL came down, regardless of how, including just diet, like I said, all of the benefits and protection, all of that stuff happens regardless of how you lower it. So those are kind of the two starting points because they're generic and they are cheap and they're very potent.
I want to ask you one question before you go on to another one. So any reason if you can get somebody's like LDL cholesterol down to 60 on 10 of Crestor, any reason to do 5 of Crestor and Zetia or
no?
Nothing. Yeah.
That would be no reason. Unless they start complaining to you, doc, I'm starting to get achy. My legs are starting to get to hurt at night. Then you'd say, okay, we'll switch you to 5 and just add Zetia. And you can even take the 5 every other day. And you tell them start out with it once a week, even be like, listen, just take it once a week. A couple of weeks from now, do Monday, Thursday, make it 3 times a week, every other day, eventually go back to once a day. If you can't, just do it every other day. No big deal. Yeah. Because still, it's the one with the longest half-life. It's like an 18-hour half-life. Out of all of them, it has the longest half-life. So even there was a trial called the Chicago trial, I believe, where they had people take Crestor just once a week. Now, it's not approved for this or anything, but they still had a 35% reduction in LDL taking it just once a week. So either way, it does definitely work. You got to be creative sometimes. Maybe I'll do a video on that one day, but like, what do you do when people get muscle aches or side effects from statins? There's all kinds of creative things you can do. You can cut the dose down to the minimum dose, take 2 weeks off, start at it once a week, add another day later, wait a few weeks, add another day. You could just slowly titrate it back up and add Zetia or other things. But if you can put them on like a low dose Crestor and get them under 60 or whatever their target is, let's say they just want to be under 100 or 70, whatever it might be, then definitely you could just do that. You don't need to add the Zetia. The Zetia just gives you a more potent additional reduction. Like if you're going to be on medicine anyways, might as well take 2 and knock it like really down, right?
Totally.
Like if somebody says to you, if you work 2 days, I'll give you $3,000. If you work 1 day, I'll give you $100. I mean, you might as well work the 2 days, right? Totally. It's just such a huge benefit. But no, I do have some patients, lower risk patients, which with lower, risk factors and whatnot, we'll just, if the one medicine does the trick, we'll just leave them on it. So that's not an issue. The next step in the guidelines would be to add a PCSK9 inhibitor. These are medications, and just like visually, imagine you got like a hand in your bloodstream, like it's called a receptor. You've got these lipoproteins floating by. It grabs it and pulls it in to the liver to eliminate them. It's like a big clasp or something, grabs the little balls, the little lipoproteins, pulls them into the liver to eliminate them. What happens is with the PCSK9s, and the reason we discovered this is people have had a PCSK9 loss of function mutation. Some people were born without PCSK9. So we figured out a way to replicate this with medications. But the problem with this is these receptors grab these and then they go back down into the liver, and then the liver degrades the receptor as well as the LDL particles. What we figured out is people with this genetic mutation is if they have this genetic mutation, the receptor is recycled back out quickly. So we invented these medications called PCSK9 inhibitors, where the receptor grabs the lipoprotein, pulls it into the liver, drops the lipoprotein off, and then goes right back out again and grabs another one. You get about 100-fold increase in these LDL receptors. So they're no longer being recycled. You don't have to keep making new ones. They stay in circulation on the outside of the liver, grabbing more and more of these lipoproteins. You get sometimes a 90% reduction in LDL with these, especially if added onto a statin, and then especially with Zetia. So you can get now a 90 to 95% reduction in lipids with adding on a PCSK9. The last one that's really relevant is called bempedoic acid. It works only in the liver. Statins usually reduce cholesterol synthesis in every cell in your body. Not some of them more than others, but generally that's how they work. Bempedoic acid works only in the liver and reduces the liver's synthesis of LDL. Now that it's not that potent because you're just affecting the liver instead of every cell in your body. Your body cells make about 400 grams a day of cholesterol, sometimes a little bit more, which is a lot. The liver doesn't make that many. So you don't get like a whopping amount of reduction, but you get like a 10 to maybe 25% reduction if you were on bempedoic acid only. Whereas with like rosuvastatin, you can get up to 65% reduction in many cases. So you add bempedoic acid, The problem with that is it's not generic and it's hard to get. Same with PCSK9s. They're not generic yet and they're difficult to get. One of the PCSK9s are an injection, so that's kind of an issue. Some people don't want to inject themselves. Although now with the GLP-1s, it seems like everybody doesn't mind injections. But they're twice a month injections. You inject yourself on the first day of the month and the 14th day of the month. There is another one called inclisiran, which you get an injection twice a year. You go into an infusion center, you get an injection like on January 1st and say July 1st. The first time you're on it, though, you get an injection on the month 0, and then 3 months later. And then after that, it's every 6 months.
Yeah, my mom started that one, actually.
Yeah, that one's a very good one. That gives people a 50 to 55% reduction in cholesterol as well. It's a normal PCSK9 inhibitor. The cool thing about that one is it's like a RNA silencing gene therapy almost. You inject this thing, it goes into your genes, into your genetics in your liver, and knocks out this one nucleotide, protein thing in your mRNA that makes it so you don't transcribe the PCSK9, so you kind of inhibit it at the transcription area, which is called CRISPR technology. It's pretty fancy. It's super cool. Hopefully in the future, they are looking into making some of these that last like 18 months, once a lifetime, things like that. So maybe down the road in the future, we'll have some of these where you only get it once in your lifetime or once every 2 years or something like that, which would be really neat.
Really cool.
Compliance would be much higher. So bempedoic acid, the nice thing about it is it's still a pill. So it's probably going to move up in the guidelines ahead of PCSK9s, I think, maybe at some point, just because it has proven outcomes now. There was a trial that came out called the Clear Outcomes study that showed that there were outcome benefits, less heart attacks, less strokes. You have to show outcomes in any of these studies. Like if you invent a new medication, you put people on it and your LDL goes down, but you don't reduce heart attacks, you don't reduce strokes, you don't reduce anything. Well, what's the point of the medicine? To make your numbers look pretty? That's cosmetic. Like niacin, for example. Niacin came out many years ago and it made your HDL go up, but you didn't prevent heart attacks, you didn't prevent strokes. There were actually sometimes more harmful events. People got acanthosis nigricans and ended up with insulin resistance and diabetes. Their HDLs actually became atherogenic. The metabolites of it were very toxic and inflammatory. So it was a no-go. There was no benefits.
And it lowered LP(a) in some people, right? With zero, obviously, benefit.
It did, but it had no benefit, right? So that's the new trials that are looking to lower LP(a) are trying to see, are there going to be outcomes benefits? Right. One of the trials was extended recently because there was no outcomes data or not enough event rates. There was not enough event rates in the trial to be able to say, well, this medicine helped. We lowered LP(a) by 90% and it helped or not. There was not enough events, so they decided to extend it. You can't keep adding people to the trial because there's only a limited amount of people. Once you start a trial, it's with 10,000 people. You can't keep adding people. Right. But what they are doing is they're increasing the amount of time they're monitoring them. If there are enough event rates that the study is powered correctly, then they'll say, yes, this reduces heart attacks by this much and strokes by that much and whatever else.
Yeah.
So that's super important. There are other medications, generally not used that often. Fenofibrates you could use if you've done everything else, like you've managed the diabetes and stopped drinking alcohol, kidney disease, all that, and their triglycerides are still a little high. You could add fenofibrates.
Any benefit, though, in terms of outcomes?
There is, but it tracks with LDL. They do lower LDL minimally, and it's by doing that it helps the outcomes. It's not really by lowering triglycerides. There's no interventional trial where we lowered triglycerides only and outcomes improved. Fibrates did that. There's several other studies. There's a chapter of that in the book, but almost every trial where we've only lowered triglycerides, nothing happened. But if you lower triglycerides with exercise, weight loss, stop drinking alcohol, get your diabetes under control, if you lower it, the lifestyle stuff, there's huge improvements. Not because you lowered triglycerides, but because you did all the right things. You started exercising, you were lifting weights, you're eating less food, you lost a bunch of weight, you stopped drinking alcohol, your diabetes control improved or reversed a bit, whatever it might be. So with lifestyle, you could definitely improve triglycerides and your outcomes, not because you lowered the triglycerides, but because you did all the other stuff right. Any trial where we've only lowered triglycerides with medications has not shown any benefit as of yet.
Yeah. Okay.
I will add, statins are the first line treatment for high triglycerides because they lower them, but the risk reduction is not from lowering the triglycerides. It's from LDL.
Yeah. Okay. I asked my followers when I found out I was going to be able to interview you, I asked them, if your cholesterol was high, would you take a statin medication? And if not, why? And I did like open answer, and I got a ton of people that put things in. And so I want to go through these. And one of them is I wouldn't take it because statins cause insulin resistance.
Okay, so this is a really good question. There was a study done, and there is a large part of there's a chapter for that, obviously. Mm-hmm. You're going to be busy reading. There was a very large study recently done. There's been several of them. Even if you go back to the older studies, like the Jupiter trial, which was 2001, 2004, that was the big rosuvastatin trial. There was a slight increase in A1C. People went from 5.8 to 5.9. But you have to have had an A1C. You have to have diabetes to begin with. No one is going to go from a 4.8 to a 6.8. Like, that's just not possible. The medicine cannot give you diabetes. There are several classes of medications that we call them diabetogenic. They're slightly diabetogenic. Hydrochlorothiazide, like thiazide diuretics, are a little bit diabetogenic, and beta blockers, one of the most common used medications in the world for blood pressure and heart rate and all kinds of other things. They're slightly diabetogenic, and there's several others. But there was a slight amount of increase in A1C. But that little blip from 5.8 to 5.9, which was a 0.1 increase, also came with a 46% reduction in all-cause mortality, cardiovascular events, cardiovascular death rates, heart attacks, strokes, non-fatal MIs, all of that. So you're looking at a trade-off. You increase your A1C by 0.1 versus some, significantly huge reduction in all the other stuff. Now, a recent study was published, several of them actually, but the big one was a 5.4 million person year of follow-up study. They looked at this again. They said the two most potent statins, Crestor and atorvastatin, at the highest doses did also push people slightly over the edge or intensify diabetes therapy. Like if you were a 6.4 and bounced to 6.5, now you're suddenly diabetic. Or let's say you were 6.8 and you bounced to 6.9 or 7. Now we have to intensify your therapy or your treatment. They did find that, but they said these were also in people that were already diabetic or pre-diabetic. So it was not like, it wasn't, you don't take somebody who's non-diabetic and magically give them genetics of diabetes. We really can't do that yet. We wouldn't want to. But they don't suddenly make you diabetic. You have to have the genes for it. You have to be pre-diabetic or diabetic. They may push you over the edge slightly, but with today's modern medications like GLP-1 inhibitors or receptor agonists that cause weight loss, with SGLT2s like Jardiance and Farxiga and whatnot that cause a significant amount of reduction in A1Cs, as long as with metformin and lifestyle and all of that, you almost won't even really notice a pattern of a increase in A1C or any of that. So I don't think in today's
people are going to be
world,
so well controlled in general. You're saying that it's like, okay, right, a 0.1 isn't going to matter because things are so much.
I don't even think you'll have that 0.1 if they're on the right medication.
Oh, interesting.
As their weight comes down, usually their A1C comes down because metformin makes you poop out sugar, calories. The SGLT2s make you pee them out, and then GLPs make you not eat them. So regardless, most people's A1Cs are going to be going down. And if you're put on a statin medication in today's modern world of diabetes management, you're going to reduce your atherosclerotic risk in addition to any risk that may come from the diabetes improving.
Yeah, that's really interesting. And I always tell people, I'm like, even if this is your fear, why don't we just test your levels? Like, why don't we put you on it and then retest your A1C in 3 months and see, are you all of a sudden diabetic now? Like, obviously, I don't think it's going to happen. We don't have
if their A1C is like 4.8, 5.1, they're not going to be diabetic. Right. But if somebody is diabetic, the problem is there's so much fluctuation in A1Cs anyways. I don't know that you could even attribute it to the statin. Like if their A1C is 6.1, then 7.2, then 8.5, then back down to 6.4, like, how are you even going to know that one variable is anything since it bounces around so much?
Yeah, good point. And this is all about risk-benefit ratio, where it's like if you're getting this huge benefit and a tiny risk, then we're still in the positive. Okay, next one is I wouldn't take a statin because they reduce vitamin D. Oh, and hormones.
Yeah, they definitely don't. People think that because cholesterol is the building block of all hormones, vitamin D, testosterone, estrogen, progesterone, cortisol, adrenal, corticosteroids, all of that. They think that if we lower cholesterol, that you're going to reduce the production of all of these hormones. Turns out this is not true. This is super easy to study. I don't know why people think this has never been studied before or never been thought of, but it's absolutely true. So people with very low LDL cholesterol levels, like insanely low, like, in the 4-year trial, the Rapatha trial, there were people with LDL cholesterols in the single digits, like 5, 6, 7, 0.2 millimoles, because they measure it in, international units. But they had insanely low cholesterol levels. None of them had, deficiencies from that in terms of hormones, vitamin D, testosterone. There have been studies done on just testosterone, vitamin D, and all of that. No one ends up with super low levels of any of these things just because their cholesterol is low. The other thing is too, if there were a scenario where your testicles or ovaries or adrenal glands or any hormone making organ, they're called steroidogenic organs, any of these steroidogenic organs needed cholesterol, they wouldn't even get it from an LDL. They have a receptor on them called an SRBC1 receptor. They would actually grab an HDL and they would take some of the cholesterol out of the HDL. Now that happens in less than 3% of the time. You'd have to be like in the hospital, super sick, super septic, almost on your deathbed in order for your ovaries, well, it would be your adrenal glands in this scenario, where they would need more cortisol and they would need to grab some cholesterol from your HDLs. They would not take it from LDL particles at all. So that's also a misnomer. People think that if you suddenly need LDL, cortisone or testosterone or cortisol or whatever, that you would need high LDL or high cholesterol. They're not. It's not how it works. You need it. You would get it from HDLs, and there's a receptor called the SRBC1. That's how they would get their levels. They would not get it from LDL at all.
LDL. Yeah, interesting. We already answered this one, but another one was you should change your diet and exercise first. You don't need medication. We don't have to go through that again. Obviously,
we absolutely agree. You absolutely should change your diet first. Totally. And we went over exactly what to do.
Yeah. Super common one. You touched on it before. They cross the blood-brain barrier and increase the risk for Alzheimer's, Parkinson's, dementia. That's why one person wouldn't take them. Obviously, you already said that they reduce the risk.
They reduce the most recent trial, and I've posted these videos. And all of these trials, most of the chapters in the book are blog articles, and I use the copyrighted images because it's free. I can't sell the copyrighted images like the diagrams and the force plots and all of that. But the force plots are super clear. Anybody on a statin, like there's 30 different kinds of cancers, risk that is reduced. And anybody on a statin, every neurodegenerative disease risk was lowered. All forms of dementia, all forms of Alzheimer's, ALS, MS, multiple sclerosis, any of that. Now, don't get me wrong. There are some people that say, it's got this weird brain fog, something's not right. We see that, and that is not a big deal. We can usually swap to another statin and it goes away. You tell them to stop it for a few weeks, put them on a different one, usually Crestor, since it has the least amount of like weird interactions and side effects. And it might be Crestor, you could switch them to a different one. But usually just swap it to something different and that goes away. No one is disagreeing that some people will have some weird symptoms. Absolutely. Same thing with muscle aches. Some people get muscle aches. If they're not intolerable and they just kind of bug you, you could leave it alone. If they're really intolerable and you can't do anything and it's encroaching on your life, then sure, we could switch to a different statin, lower dose, add something different, you switch to something different altogether. If you've tried several, there's all kinds of ways to manage the side effects of these medications. You don't have to have side effects.
Right. Yeah, that's an important thing to note. One person said studies show that statins only increase lifespan by 4 days. That's why I wouldn't take one.
So there's a very long chapter in the book on that. And also on the blog, if you want the free version, because not everybody's going to go buy a textbook. And there's a YouTube video on it. But this was one study that was published by authors who the authors themselves didn't even agree with their findings. This study was looking at all the older statins and some of the older studies where people were put on statins for several years. Like you're on a statin, like the Jupiter trial was 18 months. There was another trial that was like 3 years or 4 years. They looked at all of these trials and they had projection models. These were not actually real. Like they didn't actually follow people till death, but they projected out how much more time being on that statin for the time of the trial would actually extend your life by. So if you took Crestor for a year and then stopped, do you anticipate any life extension?
No.
0. Yeah. This is like a smoker who smokes every day of their life, and you tell them, you know what, for 2 years, just stop smoking and then go right back. Is there any chance that they would extend their life? No. I'm surprised it was even like 3.5 days for one, 4 days for another, 7 1/4. for another thing. So you're not going to have any additional benefit. But if you tell that smoker, stop smoking now and don't ever smoke again, the area under the curve for that study or like in the trial would continue to expand. You absolutely would extend their life. Same thing with these statin medications or any lipid lowering therapy. If you are on Crestor, say, for example, from age 30, and you only took it till age 32 and stopped, nothing's going to change.
Right. What about that 30-year-old though? You're probably going to finish this. I'm probably interrupting you.
Yeah,
30-year-old that's on it until like they're, 85
exactly.
till they die. Yeah.
Till they're 90, right? The area under the curve continues to expand. Their risk of having anything atherosclerotic goes way, way down. And we know that's the number one killer. And statins reduce all-cause mortality and reduce all kinds of other things that we've evaluated. The area under the curve is going to continue to expand, and you're going to add decades to your life. Modern medicine, it's estimated now, has added probably 30 years, maybe 50 to our current lifespans and health spans. Like, you're living longer, but healthier. Like I always tell people, what's the point of living to 100 if the last 30 years are going to be laying in bed in a nursing home, unable to function? No one wants that. But if you're able to deadlift and go for walks and walk the dog and play sports with your friends at 80 or 90 or 100, that would be optimal. So modern medicine has added decades to our lives. Obviously, this study, the online idiots, let's just call them, have run with it because there's like, oh my God, statins only add 4 days to your life. Well, they looked at studies that were short-term studies for just a few years. And of course, it's not going to add anything. Like, I'm surprised they even came up with 4 days. They should have came up with nothing.
Right. Really poor study design.
They don't understand it.
Yeah. Okay. And say for me, like I've been on Crestor since my early 30s. If I stay on for my whole life, do you know, like, is there a stat about like I may add 5 years to my life? I may add.
So I don't know that we know that exactly, but we could guess probably 5 to 15 years. It just kind of depends. Like, we don't know what technology is going to come up in the future anyways. But if everything never changed to, like, if everything were to stand still like today, like I take Crestor too, and I've been on it also like since my 20s. But if everything were to not change and no advances in technology or anything, we've already added a very, like part of that chapter in the book is looking at lifespans. A 15-year-old born in 1900, it was only expected to live about to 45 or 50 at the most.
Right.
There's no 15-year-old today that is only going to live to 45 or 55, like on average, obviously get into a car accident, whatever. But they're most likely expected to live into their 80s and possibly a lot longer. Now that we can remove the burden of chronic disease with these GLP-1 inhibitors and, receptor agonists, I should say, and weight loss and, nobody really being overweight and having all these chronic diseases, who knows what's possible? I mean, you could easily add another 15, 20, 30 years to people's lifespans with the cancer treatments improving, the heart disease treatments improving, remove weight loss and obesity out of the equation now, and people could easily add, several decades to their life maybe.
Yeah. Another person says, I wouldn't take statins because we already talked about that one. They deplete CoQ10.
That is just not true. There's no evidence that CoQ10 helps with anything. We would prescribe it with statins then. And all these pharmaceutical companies would make combo pills. Like, why wouldn't you make Crestor Q10? Like, it would be the next billion-dollar drug, but they just don't do anything. And no one's going to invest time and money into producing something that no one's going to prescribe. So plenty of farm reps come over and like, Doc, we got this new medication. It's like a combination of aspirin and Protonix, and it's $300 a month. Like, why would I prescribe 2 generics and a combo pill and my patients have to pay $300 a month? Like, or there's no data. Like, we had a medication called Multac in the cardiology world. It had no efficacy, dronedadrone. It was supposed to be the next greatest amiodarone or something. It doesn't work. It has no efficacy. Why would I prescribe a $3,000 a month medication that does absolutely nothing? And there's been several other options like certain fish oils and niaspan and all kinds of things that they don't work. Why would we continue to prescribe it? No company is going to invest in something that just doesn't have the outcome data.
Yeah, people are coming from a perspective of CoQ10 where the statin works by inhibiting a certain enzyme, and downstream from that enzyme, right, is CoQ10. And so they're figuring if you're inhibiting that, then you're not going to have any CoQ10, and CoQ10 is needed throughout the body. But I think your point is that there's no negative consequences to inhibiting that pathway in terms of the CoQ10. Your body has enough to actually do everything that it needs to do, and we don't see improvement when we add CoQ10 back in too. We've had studies that look at that.
Right. There's no definitive benefits or negatives from adding or not taking that.
Yeah. Okay. Okay, this is a really common one where people say, I wouldn't take a statin unless my coronary artery calcium score was high, but I have a score of a 0, so no need for me.
So this one, I'm going to do a visual explanation. But
Yay.
I'll describe it. I'll describe it with words too. So this is what a normal artery looks like. It's wide open. There's nothing going on. Early atherosclerosis, your cholesterol is high. You start to build up some cholesterol soft plaque, more soft plaque. Notice the artery remodels outwards. It tries to stay open. This is the lumen. This is where if we inject dye with a CT scan or a cardiac catheterization, you would see that it's pretty open. It keeps going. Here in the final, like late stages of disease, this is where you would see calcium. And you don't want to wait.
What are we talking about from a time course of the first one?
This is decades.
Yeah.
Well, it depends. Like if you have lipoprotein A and cholesterol of 300 your whole life, it would be sooner. But the average person, let's say with an LDL of like 130, no lipoprotein A, not really a lot of risk factors, maybe just hypertensive and obese, you're looking at decades. So the problem with calcium is it's a late stage finding. Same thing with CT angiograms. Like, the model I just showed you, the lumen doesn't really start to get narrow, till the end here. This is where the lumen finally gets narrow. It's like pretty wide open here. Finally, here at the end, it starts to get narrow. So any angiogram, like a CCTA or a cardiac catheterization that I do in the cath lab, and we read all of these studies, obviously, but you're testing for end stage or very late stage disease. Why would you ever want to do that? Like, why would you tell a smoker? This is the example I always use. Why would you tell a smoker, keep smoking? We just did a CT scan and it was normal.
Yeah.
Another 5 years later. 5 years later, oh, we finally found a nodule or we finally found some lung cancer. Now you should stop smoking. It's kind of too late and it's irreversible. The damage has been done. Same thing with calcium or these, CCTAs. You're doing testing that tests for very late stage disease when we have ways of preventing it before it even starts. So I don't think that we should wait. Like, I'm a preventative cardiologist. I'd prefer for us to prevent cardiology. I'm sure you want to prevent heart disease in your patients as well. Why would we wait till something's almost completely irreversible, has already taken hold, and is not going to get out of there? Like, imagine trying to dig calcium or concrete out of your arteries. It's just not going to happen. We have ways of preventing that, and we might as well use them. There's no reason to wait till it's completely irreversible.
This is a funny one for me too, because no, totally. And I completely agree with you. And it sometimes comes from people who are very much in the health space, which I find interesting, where it's like,
it comes from cardiologists even. That's the sad thing. Like, I've had people in my community, I have like a private online community. They'll come to me like, my cardiologist, my LDL is 143, which is insanely high. And I went to see a cardiologist who claims he's the best cardiologist in New York. And he told me, let's get a calcium scan. Like, what? And I had another guy whose lipoprotein A was like 289. He went to see a lipoprotein A specialist who told him, let's get a calcium scan before we put you on anything. Like, what? Are we insane? Like,
literally pointless, regardless of what it comes back as, even.
Regardless of what, like, you shouldn't order tests unless it's going to change your management. It's not going to change my management with somebody with these people. They need their LDLs down to the 20s and 30s almost regardless. I mean, who tells somebody with lipoprotein A that your LDL, that we need to check something first? Like, what? Like, that's crazy. That needs to be as low as humanly possible.
What do you think about the Clearly scans and those technologies that are using the CCTA with the AI?
So they're also not that good. Multiple people, cardiologists read CT coronaries all the time. There's some, like, the hospitals that I go to, the radiologist doesn't read them. I do. And then other places, cardiologists read them that are imaging specialists. They are still measuring lumens. Like, there's still a luminography. Like, we are injecting dye into the lumen to see if the lumen is plugged up. You're not going to catch problems until they're bad. And even the Clearly ones.
They say that they can see soft plaque, though. Do you think that's BS?
I've looked at the Clearly ones. Multiple people have sent me them. They're okay. They're not that good. And one of them, I actually commented back to the person, God, I can't believe how bad these images are. But they're not that accurate. I don't think they really help with anything. There is a new type of CT technology called photon counting. Those will actually be really good. And we're finally getting to the stages where actually we could see inside the lumen, or inside the arterial wall, not the lumen. We could always see in the lumen. We're finally starting to be able to see inside the arterial wall with this photon counting technology. It's not that common. It's still kind of research based in like these large research centers. That type of CTA or CT scan will definitely be able to see those kind of things. So I think maybe until the imaging technology improves and catches up or gets a little better, I think we're kind of stuck with what we have now, which hopefully, like right now, the Clearly and the CCTAs and the CAC scores and calciums, I would not even touch them.
You wouldn't bother with them. You're just going to treat no matter, it's not going to change your...
Like for me as a preventative person, no matter what, they need to go down, like regardless of whether they have anything or not. It's like a smoker. If you're working in a smoking prevention clinic, you're not going to tell a smoker, you know what, you're kind of on the border. Let me think.
Yeah. Right now I use them. Yeah, right now I use them in practice. Well, I'll say this conversation may change what I actually am doing, but right now the big piece is like I have some people who like push their feet into the ground. They're like, I'm not doing a medication, and their levels are crazy. And I'm like, is this something that if something is seen that may tip them into saying, okay, yeah, I'll treat it now.
The problem is these are usually younger people and their scans are going to be normal anyways.
They're going to be normal anyways, yeah.
I would just work on my convincing skills and say, listen.
Well, this is why we're doing this podcast. I'm going to now send them this podcast link.
It's not going to help you. No matter what this scan shows, your cholesterol is insanely high. And we know what happens decades later. You use the example of the smoker. Would you tell a smoker to keep smoking till we see lung cancer on their CT scan? Probably not. That would literally be insane. Like that would be malpractice. That's the way I look at it. So me personally, I don't order them, even though we do read them and all of that.
Yeah.
There are certain scenarios where they're ordered in the emergency room, which is totally understandable. Somebody comes in with crushing chest pain, stress test is not available. They might have a pulmonary embolism. They might have an aortic dissection. They might have a coronary. That's totally understandable. A CT would die. Absolutely will rule out all three of those things. They call it the triple rule out. No big deal. Mm-hmm. But definitely in the outpatient setting, I don't find a helpful role for it.
Okay. Super helpful. We're almost getting to time. I'm going to scan to see. Let's do a case study because I think these can be interesting. This is going to be a combination. If people are listening and they're interested in this idea of lean mass hyperresponders, this case kind of would fall into what these people are talking about. So 25-year-old woman, ideal body composition. So let's say her body fat is 20% body fat. She's normal body weight. Her insulin levels are normal. Her CRP is less than 1. Her LDL is 130-ish high. Triglycerides are normal. No family history of cardiovascular disease. She's adequately muscled. I tried to put any detail in here that they'd be like, well, what about this? So just really, quote unquote healthy.
Basically like the healthiest person you can imagine just has an LDL of 130.
Exactly. Like that's the only thing that's there. This person comes into your office. What are you telling them?
So there is an entire chapter on lean mass hyperresponders in the book too. And it is a blog article that's completely free and the links are live. You can go read all of these studies.
And you have a great podcast on this. I want to refer people to where
I just posted a long YouTube video, which is also the audio version of it is a podcast on it. So there have been a lot of studies on this. People think that this is some new phenomenon that has never been studied before. And there's all these magical unicorns out there that are these magical metabolically healthy people that never get atherosclerosis. The studies that have been done on this are done by, the PISA trial, the Cardia trial, Dr. Jidra Tobias did a huge thing on especially women. It was the women's health study cohort. She went through and picked out these quote unquote lean mass hyperresponders, and the results were not good. Anybody with a high LDL for a long enough period of time is going to get atherosclerosis, regardless of what your CRP levels are, your body fat percentages, how much you work out, how healthy or unhealthy you eat, whether you smoke or not. That's not a question.
Inflammation, no inflammation.
Right.
Yeah.
Yeah, whether you're inflamed or not. In fact, the arteries develop atherosclerosis when they're not inflamed. There was a large study done by Tabas and Williams where they wanted to see, does inflammation even matter? And it turned out it doesn't. And injury doesn't matter, whether the artery was damaged or not. It didn't matter. You needed healthy, intact endothelium actually to end up with atherosclerosis. So there's these people that are doing this LMHR study and they think it's something novel and what have you. Unfortunately, they've been caught just kind of making up data by numerous people that have kind of refuted them now. And it's become almost a clown show online. They just post random clickbaity, crazy stuff to get popular. It is what it is. I can't really comment on their motives or why they do that, but their methods are flawed. Their analysis is flawed. Their data is kind of all over the place. And lots of people have published entire publications outlining why their data is just completely made up in some of the trials and studies that they've posted. And they reference their own trials and studies, which is kind of weird.
Mm-hmm.
But there was lots of studies on young people that are super healthy. The PISA trial was one of them. The Cardia trial was another one, looking at 18 to 36-year-olds in the Cardia trial, 40-year-olds in the PISA trial. They were non-smokers, no calcium scores, LDL cholesterol is all over the place. They controlled for every confounder you could imagine. The higher the LDL cholesterol, the more likely you were to have atherosclerosis, without question. And the people with atherosclerosis had it in more than one arterial bed. 63% of people with atherosclerosis in one arterial bed had it in another one. In the Cardia trial, they followed these people. The higher your LDL cholesterol, the sooner you had the time to first event, like the time to first heart attack or a stroke, for example, was earlier and earlier. The lower the LDL cholesterol, like people in the 70s, 80s, 90s, below 100, they had a delayed time to first, coronary or cardiovascular event. Mm-hmm. And these were all healthy people, with low BMIs, no calcium, nothing you'd imagine. So that would be where I would point people to. There's a very long YouTube and a podcast and a blog article on that.
Yeah. I don't want to end this podcast. I have so many more questions for you, but I'll
fire away. We've got time.
The Lp(a), we got to talk about. It's one of the markers that I run on every single one of my patients. Like you said, you don't have to run it over and over again, but we run it once. I do run it again if after a woman goes through menopause, and I'd love to hear your thoughts on whether that's important or not. But just talk a little bit about what it is and why we care about it.
So I'll just give you like a visual again, but I'll describe it. Imagine that lipoprotein, like a baseball again, and there's like this little like kringle or C-shaped, crescent-shaped thing around it. This is a kringle. This is what we call the lipoprotein A. They come in different molecular weights. There's bigger ones, there's smaller ones. This makes your LDL particles 3 to 6 times more atherogenic. The problem is it also attacks your aortic valve. People who get early onset aortic stenosis, what we call CAVID, calcific aortic valve disease, or a calcified aortic valve. Basically, the calcium in the LDL, the lipoprotein, whatever, destroys your aortic valve in a way that it, calcifies and gets very stenotic. People get atherosclerosis maybe decades before they should. Mm-hmm. We normally don't anticipate aortic stenosis or atherosclerosis till people are like in their 60s or 70s, assuming everything else is normal. But their LDLs look kind of normal. Let's say it's like 100, 120, nothing insane, maybe even 90. But they ended up with a aortic valve replacement or open heart surgery at age 45, 50, something ridiculously low. 40s for men, 50s for women, just very low. These are the people you want to check lipoprotein A on. Now, obviously, you should check it on everyone, but, most people don't do what we do. And, when I see them later in follow-up in clinic or, as an outpatient, I would order this on them because it's like, almost criminal not to. But almost everybody should get this checked at least once in their lifetime. They can fluctuate a little. There's like a 10 to 20% fluctuation here and there. It is an acute phase reactant. So if somebody's, pretty sick, it's going to go up. So there's almost no point in checking it when they're hospitalized. You can, because sometimes you might not catch them again or might not see them again. And it's not like it's going to, suddenly go to negative if they're elevated. The higher, the worse, obviously. Some people are greater than 400, 600, 300. If it's just barely over the limits, still bad, but not as bad. I'm not sure if there's a correlation with when people go into menopause or not. If they were negative before, probably unlikely that it would be positive afterwards, but I'm sure there's data on that. I could look that up or ask Dr. Dayspring maybe. He's the first doctor in the U.S. actually to be board certified by the National Lipid Association as well as the Menopause Society. So I don't know if you have
he's wonderful.
Twitter or whatnot, but you can ask him, or maybe I'll ask him later today. But if it's elevated, it increases your risk of heart disease 3 to 6 times what it normally would be.
Yeah. And so Quest, I think the cutoff is like 70 at Quest. Somebody is in like...
In nanomoles, it's 75, and in milligrams, it's 30. So it kind of, or 29, just depends.
Right. Depends on the units. And so somebody comes back and they're at the 300 range. What are we doing for this person?
So you're getting their LDL down to as low as humanly possible.
Yeah.
Usually we say under 40, but the lower the better. If you can get them down into the 15 to 35 range, that would be fine. You want to reduce. So imagine like you have a lot of criminals in your city. You have like 3,000 criminals. 2,800 of them are just bad criminals, and then 200 of them are super bad. If you can get rid of the 2,800 that are bad, you can probably reduce your risk of atherosclerosis by 80 to 90%. even though that 200 bad guys, the super bad ones are still there. So it's kind of like that. You got like really bad cholesterol and just bad cholesterol. If you can get rid of most of the bad, you'll do a lot better off, even though you can't really get rid of the super bad. PCSK9 surprisingly do lower LDL or lipoprotein A, almost 30%. So that might not be an option. If you put them on like Crestor and they get down into the 60s and you say they're not at goal, and then you add PCSK9 and they get down into the 15s or 20 range, that's not a bad idea. You don't need to check it again, but you've at least reduced it significantly.
But do we think that will improve outcomes by reducing LP(a) through PCSK9s if it does?
We don't know.
Yeah.
We don't have data on that, but we do know it does reduce it about 28%.
So maybe might as well try kind of thing? Is that the rationale?
You've got nothing to lose. I mean, nothing bad happens, so you might as well reduce it since we kind of can.
Right, that makes sense.
Until medications come around.
Okay. I got some more questions from followers. One person asked, is aspirin good for clot prevention? When would you recommend somebody takes aspirin?
Yeah, so aspirin is one of the few medications that has been proven that, the test of time. People are like, well, I want to take nattokinase and K2 and all this stuff. I'm like, we have a medication that beats streptokinase. Streptokinase is a real medication. It's a clot buster. And it was proven and it was approved and it works and you can still prescribe it. Aspirin beat it in the ISIS-2 trial. So why not take aspirin? It's actually a real medication. People are like, well, I only want to take natural substances. Aspirin is oil of wintergreen. Like literally it's oil of wintergreen. Salicylic acid comes from the bark of a willow tree. We just purified that molecule and turned it into a medication so that we can actually dose it and you're not overdosing and bleeding to death. But no, aspirin is fantastic. Yeah. I don't know when you should take it. If you don't have risk factors, you probably shouldn't. But if you are slightly older, you've got hypertension and diabetes and, LDL cholesterol that's elevated, yeah, you absolutely should take it. If you keep having bleeding, complications and all that, and you don't have heart disease, then you probably shouldn't take it. But if you do have stents or you've had heart disease or high lipoprotein A or something, you almost need to be on it indefinitely. So it really depends on what scenario we're talking about. Another thing people bring up is these ratios. I don't know. Did you get any questions on ratios like HDL, glyceride ratios or anything like that? Yeah. That is a big misnomer too. People think that that all of your risk comes from the ratios, which is absolutely not true. The ratios can give us indicators, like you said earlier, of are you diabetic or not? Do you drink too much alcohol? Maybe you're overweight, you have kidney disease, etc. So the triglycerides by themselves can do that. Comparing it to a ratio, with HDL in it is nonsense. HDL has way too much racial and sex variance. African Americans, Hispanics, white people, women, too much variation that using it in a denominator when it's such a low number, it's like 30, 40, 50 at the most, sometimes higher. But you're looking at a very small denominator and, numerator sometimes, not always whopping, but sometimes it makes no sense to look at it. Like the person with a ratio of 1.5 versus 2.8 versus 5.0 is not going to predict your outcomes in terms of heart disease more than just a pure straight up LDL number. So makes no sense to look at ratios. The HDL in and of itself, if it's super low, obviously can make us believe you might have cancer. Same with LDL, but it can mean you have untreated diabetes or insulin resistance or things like that. So those ratios, or at least looking at triglycerides and HDL independently, not even in a ratio, can independently help us determine if you have some kind of metabolic derangement, whether it's insulin resistance or too much alcohol or obesity, whatever. But you can't just hang your hat on it. You have to actually check for diabetes and, do they actually drink alcohol, whatever it might be. But the risk alone is determined by LDL cholesterol or ApoB. If you had to just check one single thing, it would be ApoB. That is going to be that's the money shot. That's where the cholesterol risk, atherosclerosis, peripheral artery disease, all that stuff is going to come from ApoB by itself. So there's almost no point in even worrying about ratios. Triglycerides by itself is helpful. HDL by itself, maybe not so much, but definitely no need to look at any ratios.
HDL by itself, are you ever making clinical decisions on that? And what would be a case where you would? Never. Yeah. Absolutely
none. HDL you can just throw away. Other than if it's insanely low, send them to a cancer doctor.
Right. Yeah. Okay.
Like if somebody comes in with an HDL of 11 and an LDL of 34, there's no reason why it should be that way, which is almost never. Like even if they're on medicine, It would never look like that. They need to see a cancer physician. They have leukemia, lymphoma, one of these blood cancers, lymphoma, leukemia, multiple myeloma, one of these things.
But HDL comes abnormally high, like it's like 130. Is that telling you anything that you're going to use? Nothing. Okay.
Nope. Other than the fact that it's probably not functioning very well.
Right.
It's dysfunctional, but we don't have a really good HDL function test. We don't have testing to help us determine if it's functional or not. So
yeah, and you're talking about it's probably more atherogenic than somebody who has a HDL of 50 or something?
Not at all. No, it just means that it's not clearing cholesterol as much like it should be. Okay. So your cholesterol is going to be a lot higher. Your proportion of total cholesterol that comes from HDL is going to be higher. We don't know that even really matters. You still need to get your LDL way down.
Right.
But there's no data right now that says either that's good or bad. So HDL right now is just kind of we'll figure it out at some point in the future, but it's useless right now.
Yeah. Okay. Somebody is eating well, they're exercising, all their lab markers are in good ranges. Like just think of like the, epitome of health, even their LDL, like everything just like looks great. They're taking whey protein, they're taking creatine, they're sleeping well, they have healthy relationships, yada, yada, yada. You get the idea. Anything else that you think could help this person live a longer, healthier life?
In terms of medications?
Anything. Yeah, I'm just talking from a longevity lens, things that you believe in.
So they're already like exercising and doing all that?
Yeah. Ideal body comp. They're already doing all.
And their LDL is like already 20 or 30?
Perfect. Yeah.
Everything is
perfect. This person doesn't exist pretty much, but I'm just getting to like, is there anything else that you believe that can give people improvement in quality of life or lifespan that's available to us right now?
If they're doing everything you just said and they match that exact description, there's not a whole lot you can do. Sometimes people want to sell you some crazy nonsense like saunas and blue blockers and detoxes and cold plunges and all this stuff. There's just no data. They're fun. Sauna might feel good, acupuncture, massage, whatever, but there's no data that shows it's going to add longevity or improve your life or any of that stuff. So I think a lot of that is, these people, a lot of these like pseudoscience-y podcasts they have deals with a lot of the manufacturers of these things. Like if you buy my cold plunge, buy my blue blocker glasses, or my sauna is the best kind. And there's a lot of financial reward for maybe saying some of these things because they advertise on their podcast. Personally, I don't run any ads on my podcast at all. I didn't even take any money to publish my book. It's completely my blood, sweat, and tears and away time, 2 years of my life away from my family. But I did not take like any funding from any institution or medications or any of these, things. But I think a lot of that is trying to push products onto people that they generally don't need. Like this guy, Sinclair, tries to push the NMN and NAD and all this nonsense. There's no human data that does anything. Charles Brenner keeps challenging him to debates and he just keeps declining and even blocked him. Charles Brenner is actually like a real longevity expert. You might want to interview him.
Yeah, he's on my list.
He's a fantastic, very intelligent longevity person. Other than having good genetics and doing exactly what you said, eating right, getting your ApoB down to insanely low levels, exercising, which improves your cardiorespiratory fitness as well as muscle mass. There's not a whole lot more you could add to that. I mean, not even a smidge. People are like, well, what if you did everything right and now red light therapy helps? No. And now sauna helps? No. It just doesn't. I mean, I could lie to you and make up things, but there's no. It's just no.
Okay, good. I like the honesty. If somebody's going to design the perfect cardiovascular like workout over a week, what would that be in terms of like steady state, high intensity? They're already resistance training, like that's separate. Just from
lifting weights.
They're already lifting weights. Yeah.
You want to push your body to, so it depends on what your goals are. Like I'm a certified personal trainer.
Just living the longest. So just a longevity preventative medicine. Yeah.
So the studies we get on this have a lot to do with the stress testing, the Bruce protocols on the stress test, because it's standardized. Hundreds of thousands of people every year go through the Bruce protocol, which is a protocol on a treadmill for a stress test. The highest, fittest level, the quintile, the highest quintile versus the lowest quintile is always a good comparator. And there's a huge section in the book on that towards the end on longevity and blue zones and et cetera. If you are able to do cardiorespiratory fitness in a way that challenges you, where you get your heart rate over 100, but not always up to 200. Like it's not necessary to go all the way max 90% of age predicted maximum heart rates. But if you're between the 60 and 80% range, and there's like all this stuff now talking about being in zone 2 and pushing yourself to the limits and doing HIIT exercise. I think that's getting too deep into the weeds.
Details?
Yeah, as long as you're pushing yourself. And also the problem is at certain levels of cardio, you're interfering with muscle building. If you're running 26 miles a week, preparing for a marathon, you're not going to be building a lot of muscle. I mean, there's just too much of an interference signal. At lower levels of cardio, there's not as much. I mean, and there is some, doing some cardio helps you lift weights better and longer. Lifting weights helps you do more cardio to a certain degree. So there is some overlap, but I don't know that there's like a fully defined exact type of program. If you're pushing yourself, like if you're lifting weights and your goal is hypertrophy and muscle building, that should be your focus. Do cardio once a week, to a point where you feel kind of tired. You're exhausted. It is quite a workout. It's not going to interfere. If you're generally trying to live longer and have better cardiovascular health, the cardio is a little bit more important, and you could use the resistance training more as a side thing. They both are good if you kind of do a balanced approach where you lift weights first and then walk on the stair climber for 15 minutes afterwards, no big deal. Or jog a mile or walk a mile afterwards, no big deal. Probably not going to interfere. One is not going to interfere with the other very much. So that would kind of be my approach, more of a balanced approach without, going too crazy one way or the other.
Yeah, great.
I don't know that we have data specifically answering that question.
So there's one study, and I'm going to have to pull it up because I can't speak on off the top of my head, that I'd love to show you, that talks about like the ideal in terms of long duration, lower intensity cardiorespiratory. It's basically what the guidelines are established under. The study, I've tried to reach out to the authors because I want to get him on the podcast because I have questions about it for this reason. I'm like, if we were going to design the thing that would, help people in terms of preventive medicine the best, what would that look like? And it's not super clear from it.
Yeah, I don't know that there's even a way to do that without following people around like forever, because there's not like really any biomarkers that you can, like, there's no biomarker for longevity. Right. Like for cholesterol, you can measure LDL and ApoB, and we kind of know. Yeah. For longevity, you have to put them on this program for life and see who lives longer. See who lives, and that's which may take
very expensive study.
150 years.
It
may be a very long study.
Okay. All right. Last thing, and then I'm going to get you out of here. We do rapid fire at the end. There's no nuance here. It's just, I'm going to say something that's usually coming from social media. You're going to say, is it BS or is it true kind of thing?
Most of them are BS. Most of the videos people send me like, what do you think of this, Doc? I'm like, if
some of them are not. Some I've put in. BS. So, okay. But coconut oil is good for you?
It's BS. It's bad for you, actually.
Seed oils are bad for you?
They're very good for you.
So BS?
BS.
Salt in the diet is good for you? Excess salt, like high amounts of salt in the diet?
BS. It's bad for you, actually. It increases inflammation, hypertension, all that stuff.
Eggs are bad for you?
So this one's going to require nuance.
I know, there's an amount here.
If you're a hyperabsorber or not, how many eggs are we talking? 1 or 2 a day for most people is probably fine.
Yeah. Saturated fat content is what you're referring to in eggs.
Right. And if you're a hyperabsorber, it's mostly the dietary cholesterol. There's a little bit of saturated fat, but it's mostly the amount of cholesterol that's in it. Most people's an egg or 2 a day is not going to be a problem. And it kind of prevents you from eating other junk. So it's usually not a big deal.
Fish oil supplements for heart health?
Total BS.
Yeah.
So first of all, there's no the fish oil supplements in the U.S., and there's a chapter on that. They're all contaminated. They don't even contain fish oil, not at the levels they even say. Most of them contain all kinds of other garbage that you don't need. And even if they do, like even the prescription fish oils that we have that are pure fish oil, the data is not very good, and they cause AFib. So I don't know that it's worth doing.
Yeah.
There's no good outcomes data. Let's put it that way.
Yeah, there's no benefit that we see from taking it, so why bother? Last one, sauna. You already answered it pretty much, I'm guessing. Yeah.
Unless I cut a deal with a sauna company, then all of a sudden I'll find the science for you, which is never going to happen.
Awesome. Thank you so much. It's a Saturday that we're recording right now. I really appreciate you being here. And if you guys are interested in learning about cholesterol, highly recommend this book, joining his online community, and follow him on YouTube, Instagram, all the things. He's a wealth of knowledge. I really appreciate you, Dr. Allo.
Yeah, thanks for having me. Loved it.